everyone. Good afternoon. Thanks for joining us here. We are going to get started here on the next page, learning and bonding in the NICU. I know Zoom takes a couple minutes to let people in. I see people trickling in over there, but we would love it if you haven't joined us on one of these next page events before. We want it to be super interactive as a webinar can be. So please take a minute to go into the chat and let us know who you are and maybe why you're here. Also, Liam, are you going to pull the slides up?
Oh, yes, I will.
Thank you.
That's my job.
So go ahead and go into the chat and introduce yourself. That helps us and our panelists to kind of know who's here. And as you guys are, I'm sure, familiar by now, there is a Q&A section as well. So anytime during this event that you think of a question, you just go into the Q&A and ask there. Just a note that this is being recorded and will be shared immediately after this event. So please do take a moment and share it with your colleagues or anyone that you think would be interested. I see as more people are trickling in. Thank you for joining us. I'm Chris Hoplin. I'm the Executive Director of Reach Out and Read Minnesota. Liam, can you go to the next slide?
Yeah, Chris, I do just want to point out really quickly that it says that the chat is disabled for our participants. I don't know if you have a way to quickly address that.
Yep, it should be fixed now.
All right, let's try that out.
Let's see if it works. Sorry about that. Always some technical difficulty of one or another. So the chat should be available. If not, I will fix it in just a moment here. The Q&A will just be able to see, only the panelists will be able to see the Q&A. Feel free to drop a question into the chat as well. We'll be monitoring that for the Q&A at the end. Liam, can you go to the next slide? So I think that many of you who are here probably are very familiar with Reach Out and Read and who we are, but if not, I'll just take a moment to show you this infographic of our program. So the model of our program is pretty simple. At every well-child visit at clinics that are participating in the program, a young child from birth to age 5 comes into the visit. The doctor gives a book to a child, a new developmentally appropriate book, and uses it as a prompt to talk to the family about how reading and talking and singing together can help build their child's brain. The family goes home empowered to read and learn and share books together. And the process repeats at every well-child check from infancy until the age of 5. We just came onto our 300th clinic, just came on recently. So we have 300 clinics around Minnesota that are doing the program and growing. Our model has a lot of peer-reviewed research behind it. And if you're interested in learning more, obviously, we're happy to chat about Reach Out and Read anytime. All right, Liam, next slide. I want to take just a moment to thank Health Partners and Little Moments Count. They're our 2022-23 executive sponsor, so they help us put on all of our events throughout the year. So when we think about these next page events, we kind of look at our landscape and think about questions that we've been getting and things that we think that our audience might want to hear about. And so we kind of landed on the NICU program that you're going to hear about. Reach Out and Read, we are part of a national working group focused on the NICU and using the Reach Out and Read model in a NICU setting. And so it's new for us. We're learning and growing. And I know there's other NICU programs around the country that are represented here and other Reach Out and Read affiliates that are represented here today that are interested in implementing a program like this where they are. So right now we have 2 NICUs participating in the program. We have mHealth Fairview and Hennepin Healthcare. Next slide. All right, I'm going to do some quick introductions and then we will get into the program. So our main presenter today is Dr. Lauren Buckley. I'm just going to read her bio quick. Dr. Buckley is a neonatologist and recent graduate of the Neonatal Perinatal Medicine Fellowship Program at the University of Minnesota. During the fellowship, she facilitated the development of a Reach Out and Read NICU pilot program. She's looking forward to continuing her work with Reach Out and Read in the NICU as she joins the neonatology faculty at the University of Minnesota this fall. Her research interests, which we'll hear about, are related to developmental programming of metabolic and neurodevelopmental outcomes. Liam, can you go to the next slide? We have an awesome panel for the Q&A. We're going to hear from Jenny Chomelo, who's a health expert, medical expert in her own right, and has firsthand experience in the NICU with her son, and her family have been involved with Reach Out and Read for many years. We also have Dr. Kathy Bendel, and we have Dr. Gigi Chawla, who's our medical director, and will be joining us a little bit later. So Dr. Buckley, I'll let you take it away from here.
Wonderful. Well, hi, everyone. Thank you so much for joining our webinar today. And thank you for the introduction, Chris. That was wonderful. And I'm really looking forward to talking with you all today about early literacy and brain development from the perspective of neonatology specifically. Today, I'll talk about the unique developmental risks and challenges experienced by infants and families in the NICU. We'll review non-medical or environmental factors affecting NICU outcomes. And I'll share our experience starting a Reach Out and Read program in the NICU at the University of Minnesota Masonic Children's Hospital. So to start, we'll talk about the environment. Oh, you can go ahead to the next slide. Yep, perfect, thanks. The environment that our babies experience. So on the left, you can see a nice little diagram of a pregnant mother and a fetus, thinking about the environment that fetus is experiencing in utero. And we're going to compare that with the environment that a premature baby experiences in the NICU environment. Next slide. So in utero, we know that mother's voice is a prominent sensory stimulus. And there are a few studies that have looked at how a fetus is able to respond to auditory stimulation before it's even born. So by about 19 weeks gestation, we know that a fetus is responding physiologically to sound. So we may see changes in the fetus's movement or heart rate receptive to sound. So that's still pretty early in the second trimester. By closer to term at 38 or 39 weeks, there's evidence that a fetus can distinguish between different voices. So in one study, there was an increase in heart rate related to hearing mother's voice and a decrease in heart rate related to hearing someone else's voice. So already having that bonding experience with mother. And after birth, babies have been shown to prefer familiar sounds that they heard during pregnancy. So this is a fun one. There was a study that used the book The Cat in the Hat and had parents frequently read The Cat in the Hat to their unborn fetus during the end of pregnancy, and they found that those babies physiologically preferred hearing Cat in the Hat above other books after they were born. Next slide. So let's contrast that with the NICU environment. So our NICU environment is very loud. For one, we can see on the right-hand side here, this is a picture of a premature infant born, several months before their due date, a very small baby with delicate skin. This baby has a breathing tube and is connected to a ventilator. And there's a lot of noise involved in the NICU, the machines themselves, the alarms, voices, all very, very stimulating for these babies. The NICU is also very bright. So that picture on the left is showing some proceduralists. And one of the first things that happens to our babies when they come into our NICU is they get lines or special IVs placed into their belly button called umbilical lines. And this is a procedure that's done under bright lights. We use little eye covers to try to protect our babies from that stimulation, but that can be quite jarring and probably disruptive as well. Unfortunately, there's a lot of pain and discomfort associated with the NICU, and this needle diagram is representative of that. There have been studies that show as many as 8 or more, 8 to 18 uncomfortable or painful experiences each day that a baby is in the NICU for our sickest babies. And that can be things like lab draws, medication administrations, suctioning down that breathing tube, and really many just small movements like being repositioned or routine cares can be quite noxious stimulus to these babies that are not accustomed to that. Next slide. And lastly, I included, there was this, if you could see the little mask there in the corner, and that's to represent kind of the unknown related to COVID and the decreased visiting that we were able to have, the constant masking, obscuring faces for our caregivers. And so right now it's kind of unknown what the effects of that COVID era had on the development of our babies in the NICU. Next slide. When babies are born prematurely, there's an increased risk for a number of neurodevelopmental difficulties, and that includes things like cerebral palsy, visual and hearing impairments, language disorders, learning disabilities, behavioral and attention problems. And the risk of these is increased with any complications that happen in the NICU. So infections or being more premature, having worse lung disease, having bleeding or stroke in the brain, all can increase the risk of these developmental impairments. Next. And we've made incredible advances in neonatology over the last several decades. And we have been able to increase survival for a number of extremely premature infants, and our survival is amazingly high for babies as young as 22, 23 weeks, not unusually. But those advances in mortality have not been accompanied by a decrease in preterm birth, which means we actually have an increased number of infants that are at risk for these developmental impairments. Next slide. In addition to the kind of jarring experience of being in the NICU for a baby, it cannot be understated that the NICU is a really, really difficult, challenging place for parents. And there's really an increasing body of literature, including some papers out of our own group of neonatologists at the University of Minnesota about the parent experience in the NICU. And there is marked increased rates of perinatal mood and anxiety disorders in moms and dads of babies in NICU. And we know that these are probably underappreciated or underrepresented diagnoses, and that our parents of babies in the NICU need our support as more than ever. Next slide. So we know that the NICU is a hard place to be for a baby, and it's a really hard place to be for a parent. And the question we have is, how can we minimize these adverse effects of preterm birth and NICU admission for families? First, we think about improving pregnancy care and preventing preterm birth overall. That's really the big goal, is preventing these admissions, preventing these complications. And the root of that is really reducing healthcare disparities that are known to have a profound impact on prematurity rates and birth outcomes. Second, it's kind of our job as doctors and nurses and healthcare workers in the NICU, which is really optimizing the care we provide to infants that are born early. So providing high quality evidence-based care to neonates, things like gentle ventilation and neuroprotective handling and avoiding infections. And so that's really a big focus of reduction of complications in the NICU. But really what I want to spend most of our time talking about today is promoting healthy brain development and bonding for infants and their families. So separate from the medical piece, what can we do about the environment that these families are in to optimize development for their infants? So we'll segue there into reviewing some of the non-medical or environmental factors that have been shown to affect NICU outcomes. The first more well-known intervention that we'll talk about is something called Kangaroo Care, or skin-to-skin contact. So this is a practice that's used in NICUs worldwide and is incredibly powerful, especially in developing countries in terms of temperature regulation for babies. But this is the practice of parents holding their infant directly to their skin on the chest for hours at a time, ideally, and really having a bonding and a warm and quiet and peaceful environment for these babies. There are many documented benefits of Kangaroo Care for infants, including increased breastfeeding rates, temperature regulation, improved cardiorespiratory stability and growth, decreased pain with procedures, and lower rates of lung disease and infection. Next slide. And for parents, there is evidence of decreased symptoms of depression and anxiety, and more positive parent-child interactions associated with more kangaroo or skin-to-skin care. Next, we can think about how to enrich the auditory environment, or what babies are hearing. In addition to the loud noises, the ventilators, what positive auditory stimulation can we use? And there have been a couple of studies that actually show increased objective health outcomes, improved health outcomes with various positive auditory stimuli. So first being vocal music tapes. There was a study that showed 5 days shorter hospitalization in babies that were listening to music. These are stable, slightly older premature babies, but still babies before their due date in the NICU. Secondly, another study showed that recordings of mother's voice specifically led to improved oxygen saturations for these babies. A third study showed lullaby and a combination of visual and tactile stimuli led to shorter hospitalization for female babies and improved weight gain in both males and females. And finally, I just wanted to put a plug for a current study happening in our NICU at the university, which is led by one of our pediatric neurologists, Sonia Yang, who is investigating the impact of music and lullabies on infant neurodevelopment and processing speed, which is, we're really excited to see the results of that study. Next slide. I want to talk a little bit more about listening to language specifically. And this is a really interesting study that tried to quantify language exposure for babies in the NICU and looked at babies that were less than 32 weeks gestation on less than 1,250 grams and used this special device called a Lena that can measure language. So the babies wore this in a little pocket in their onesie, and it measured the speech, the vocalizations that the child was hearing and also that the child was making, and then also measured the background noise. And they did this at 32 weeks corrected, and again, a month later at 36 weeks. Next slide. They had some interesting findings. The infants that were exposed to, or I'm sorry, the infants they found were exposed to relatively small amounts of language. So of the course of the day or the time that they were recording, only 2% of the time were these infants exposed to sounds that were language. So presumably much less than what would be appreciated if a baby was in utero hearing mom's voice throughout the day. There was an increase in the amount of language the babies were exposed to from 2% of the day to 5% of the day as the babies got older. They found that the vocalizations that the babies were making increased significantly between 32 and 36 weeks. So babies, even though they're not even at their due date yet, are showing increased efforts towards making sounds, making vocalizations, and found that exposure to parents' own voices was a stronger predictor of the amount of infant vocalizations and conversational turns compared to hearing other voices, such as nurses or other healthcare workers at the bedside. And probably most importantly, they found that the total adult word count that these babies were exposed to positively correlated with their Bailey score, which is kind of like our baby IQ test that we use in pediatrics at both 6 months and 18 months. So into toddlerhood, they found that correlation with word count. Next slide. I want to talk a little bit about the setup of a NICU itself. I think this is a really interesting case study in how we expose babies to environment, to language, and then also to think about the effect of health equity and how that fits in with that principle. So this is a picture of an open bay NICU, which is one style of NICU where you have multiple babies in care spaces in one large room. The concerns about this type of NICU, while it's quite common across the country, is that there's probably more adverse noise exposure. It's louder in general, less privacy for families. And so might be a harder place for a family to visit than a private NICU, which is an own separate room for each baby and family. If you go to the next slide, please. there have been a number of studies that have shown some benefits of private room NICUs for babies and families, including decreased length of stay for private room infants, fewer readmissions after discharge, lower incidence of sepsis, and possibly even decreased mortality, although the studies are a little bit mixed there. The next slide. We've also known that there is a lot of increased parent satisfaction with having your own space, which really makes a lot of sense. So decreased parental stress has been reported, increased skin to skin care, and increased breastfeeding rates. Next slide. What I really want to emphasize here, though, is that there was an important study in kind of the late 2010s called the Leicester study that showed that while private rooms were associated with better neurodevelopmental outcomes overall, that when they looked by insurance type, that was only true for babies of families that had private insurance, and that babies that were on public assistance did not have that same benefit. And the thought is that there may be, those babies may actually be deprived from language being in a private room because there's families may have a harder time visiting. So while we think that we're helping babies, and maybe we're helping some babies by giving their families a private space to be, it's really important to be mindful of the possible unintended effects for babies who might not have families that are as able to visit throughout the day. And in keeping with that, another study from the mid-2010s, the Pineda study, showed that in a population of infants that were in an urban high acuity NICU with high rates of public insurance and low parental visitation, that at term infants in private rooms actually had lower cerebral maturation scores and also had lower language and motor skills at 2 years of age. So the point of this isn't really to say that there's one better than the other. I think there's really benefits to both. We actually have both types of rooms in our NICU at the University of Minnesota, but I think really the point here is to think about how our interventions affect all of our patients. And if we're not explicitly thinking about equity, we may be having unintended negative consequences. And I think we keep this in mind in our Reach Out and Read project, and thinking about how we can deliberately be making an environment that is welcoming and is accepting of all of our patients. Next slide. I'm actually going to skip a couple of these here. This is just one study about a project called Books for Babies that's similar to Reach Out and Read, that just kind of describes their program and how parents felt being part of a program that gave books to families in the NICU. Next slide. The parents that were part of an intervention that were given a book and talked to about reading in the NICU were reported being more likely to read to their infants after discharge. And most either agreed or strongly agreed that reading was something that they enjoyed. And the majority also agreed that reading helped them feel closer to their baby. I think that really the heart of this study is that parents reported that the reading intervention provided a sense of control, intimacy, and normalcy in their lives. And I pulled out a couple of quotes that I thought were so special from this paper. So these are quotes of families of babies in the NICU that were given books to read to their babies. "I would never have thought to read to such a young baby. I didn't know what to say when I first saw him. The nurse told me I could read to him if I wanted to and gave me a book. I started to read and then the words came. I found it hard to talk to him, especially since he was so sick and did not respond. Reading was a way to feel close to him. In the hospital, I found it really useful to have a book to read to him. It gave us something normal to do. It humanized a very difficult situation." All right, and finally, I'd like to talk a little bit about our experience starting Reach Out and Read at the University of Minnesota. So this is a picture of our hospital, the University of Minnesota Masonic Children's Hospital in Minneapolis. You can see the Minneapolis skyline in the background of this picture. What you can't see in this picture is less than 4 miles to the southwest of here was the site of the murder of George Floyd, which occurred during my first year of my fellowship program. And as you can imagine, that was a really stressful, challenging time to be taking care of patients and families in Minneapolis, and really brought a lot of us back to asking why we do what we do and how we can engage with our community in a meaningful way. Next slide. It was during that time that our division director circulated this editorial piece that was written by a neonatologist about equity in medicine and equity in neonatal outcomes, and talked about the importance of identifying disparities in healthcare. But really what stuck out to me in this article was kind of the call to action at the end. The author had talked about starting a Reach Out and Read program in his own NICU as a way to kind of intentionally address some disparities in their community. And I had experience with Reach Out and Read from my residency time at the University of Minnesota, working at Fairview Children's Clinic, and knew the power of that program and connecting with families and starting conversations with families that were meaningful and intentional, and working on really rising the tide for all of our families. And so I looked into starting Reach Out and Read, and that's really where this idea came from. The next slide. This was a paper that I found when I took a look at what literature existed. So in 2017, a group out of Boston Medical Center published this report about a pilot, Reach Out and Read, in their NICU. Now, Boston Medical Center is a very different NICU than the University of Minnesota. It's a small urban NICU, probably more similar to Hennepin County, from what I can gather reading this. It has a very urban population, in general, less kind of extreme illness or extreme complications, less medical subspecialists, and it's a much smaller unit. It had about 20 beds, and we have about 60 beds in our NICU at the University of Minnesota, 60 to 70. Next slide. But this is really where this idea was born, to have a partnership between Reach Out and Read Minnesota and the hospital system. And there was already a robust collaboration between mHealth Fairview clinics and the Reach Out and Read organization, but continuing to partner was really a priority that we had. Next slide. The goals we identified for our program were to provide developmentally appropriate neurocognitive enrichment for NICU patients, to facilitate parental bonding, and to foster an environment of diversity and inclusion by intentionally providing books with characters from diverse backgrounds and non-English language children's books. Really, the principles that guided us here were to start small and to grow over time rather than starting large and scaling back, to be as flexible as possible, and to leverage any existing resources that we had. Next slide. So with that in mind, and knowing that our NICU is large and very acute with very sick patients, we did decide as a group to limit our kind of pilot or our initial program to just one subset of our NICU, which is called the Intermediate Care Center, which is all private room. It's 25 beds, so 25 patients that generally have lower acuity, might be within their last month of their hospitalization as they're kind of learning to eat and go home from the hospital. And there's also a specific pool of nurses that works in this Intermediate Care Center. Next slide. Our initial plan is to have a wide variety of children's books that could be distributed by the nurses once a week, and that each baby would have a shelf in their room with a dedicated area to collect these books over the course of their hospital stay. Next slide. We calculated that we needed an annual budget of about $3,500 per year for this 25-bed section of our NICU, and that's based on about $2.50 per book, which is kind of the quote from National Reach Out and Read, if I'm not mistaken. And we were very grateful to receive funds from the Benjamin Walker Foundation and the University of Minnesota Foundation to fund that first year of our pilot, in addition to the free books that are part of the startup package of any Reach Out and Read program. That was very helpful to our bottom line as well. One thing I do want to touch on briefly, because it was our biggest challenge, was navigating the staff training in the hospital world in comparison to the clinic. So there are kind of 2 staff trainings that are involved from the national program for NICU training. There's the initial reach out and read training that many of you may be familiar with. It's about an hour-long module that focuses mostly on ages 6 months to 5 years. And so we committed to having all of our medical providers, so physicians, physician assistants, and APPs, or neonatal nurse practitioners, take that full training. And then there's also a NICU specific training that's much shorter. It's about 20 minutes. It's a targeted module. It's great learning. It's really well done. And our goal is to have the nurses complete that portion, because they were really going to be hands-on, taking part in delivering the books. And then also the medical providers would take this in addition to the initial training. Next slide. So for phase 1, we set out to train our providers. And at that time, that included 24 neonatologists, 6 neonatology fellows, and about 35 advanced practice providers. Our goal was to hit 75% compliance, as we had talked about with Reach Out and Read, to move on to doing the NICU specific training. And in COVID era, and with all of the competing interests, it took us 8 months to get there. We had a couple of roadblocks. One is we really had no way to mandate this training for our advanced practice providers, who have different management than the NICU physicians. That first hour-long session was kind of time intensive and not real specific to the NICU. And I really think a big part of this too is just people feeling overburdened with new information, online modules, and really being part of that COVID burnout era. But eventually we made it to this step 2, which, sounded great at the time. We'll train our nurses. Our doctors will be happy to complete this. It's quick and easy. They're all invested. And really, despite a lot of excitement from both the nursing staff and the provider staff, we struggled again to have this NICU specific training be completed. When you really look at, even just for that 25 bed sub part of our NICU, there were over 70 nurses that work above a 0.7 FTE, which is how we define full-time for this. And again, really have no bargaining power or way to mandate the training. We learned from our experience with the initial training that an incentive may be in our favor. So we did use some of our funds to get $5 Caribou and Target gift cards that we gave to any nurse that completed our training. We used like a launch week strategy where we put up posters and got cupcakes and tried to kind of make it an exciting thing and put signs up, but still took a while to get close to that 75%. And there was a lot of confusion with accessing the module, and just overall it was a bit of a clunky system. Next slide. We eventually got close. I think we actually never quite hit the full 75, but we got close and we tried our darndest, and eventually in some conversations were agreed to move forward with just giving out books and kind of increasing engagement that way. This is just a little picture of the little sign that we gave a little handout to each family to introduce them to the program, to share that we will be giving a book every week to each baby up on the 11th floor, and to talk about reading together, strengthening bonds between babies and parents. Next slide. This is one of my favorites that actually comes straight from Reach Out and Read, is a laminated sign that we have in all of the patient rooms up on the 11th floor where our babies are participating. Talks a little bit about how to tell if your baby is in a place that is ready to be read to, or if it's better to wait until they're in a more calm and regulated state. And I think really also empowers families to read whatever it is that they want to read to their baby, and to not worry about picking the perfect book or their own reading skill level, that really just hearing their voice is perfect. These are a couple of our families that graciously agreed to have their pictures taken for a little blog post that was made about this project. But these are our families in those private rooms reading to their babies. And this is another family that actually was interviewed by the Channel 5 News, which is a fun little experience. Really, I think, again, everyone is looking for a story of cohesion and community, and I think Reach On and Read does such a great job of bringing families together, and is such a positive story that I was really honored that the news wanted to highlight that. So in terms of what's next for us at the University of Minnesota, really what I'm most excited about is kind of a new angle. We've been strengthening a partnership with our child and family life providers. So we've got two wonderful child and family life experts, Michaela and Julie, that work in our NICU specifically. We're so lucky to have that resource. And we've found that using them as a more consistent face of our program and having the task of delivering the books be theirs rather than the bedside nurses has been an amazing way to get some continuity, and families are engaging with them and kind of coming to expect the book at a certain time. And it's really been positive. I was just emailing with both of them today asking for any updates, and they shared that they've had some great rapport building with families and have been able to really enrich the program. And our nurses did an incredible job as well, but as you can imagine, they are spread so thin right now in our current healthcare system. And I think that we've increased our reliability by having our child family life team more actively involved. Over time, I really hope that we can expand this program to more of our patients in the NICU. Right now, just about a third of our patients are involved. So we've thrown around the idea of expanding to the fourth floor, which is an open bay unit, and potentially our other community NICUs, so Ridges and Southdale and St. John's and Woodwinds. But I think we want to be intentional and really perfect what we have before we move forward. So those are maybe goals for the next year, but we don't have any active plans to expand at this moment. And then, as always, continuing to increase our selection of diverse and multilingual books. We want our NICU to feel like a welcoming place where all of our families belong. The absolute last thing that we want to do is to make families feel like they are not represented or that the NICU is not for them. And so I think that is, kind of at the root of what we're trying to do is to foster community for every single family that comes through our door. So just a couple summary slides here. In summary, sensory input in the NICU is an important modifiable variable that affects cognitive and language outcomes in preterm infants. And implementing a Reach Out and Read program in the NICU is a feasible and well-received strategy to provide environmental enrichment for preterm and critically ill infants. And I would love to hear questions during our Q&A session. And also feel free to email me if you have any questions. I'm more than happy to chat. That's my email in the top left corner.
Thank you so much, Dr. Buckley. That was really interesting. And before I comment further or open it up, I'm going to turn it over to Jenny.
Hi, everyone. I'm Jenny Chomolo. I'm just here to share my experience. So I'm going to back up before we got to the NICU. So when I was 25 weeks pregnant, my water unexpectedly broke. So I was in the hospital on bed rest for 7 weeks. My husband, Nate, and I were terrified. And so we tried, like Dr. Buckley said, to bring some normalcy to our lives. So we played a lot of music. I had what was called belly bands, which is basically like headphones for your belly, that my husband would read to. Every night we spent reading to our baby. And ultimately he was born at 32 weeks. He had a growth restriction, so he was only 2 pounds, 15 ounces. He was born in an OR. It was very bright. It was loud. The NICU team was right there to receive him. Nate went with our son right away. And he was talking to our son Inchari, and all of a sudden Inchari started looking over at Nate, and the nurse was like, he must know your voice. So Inchari was in the NICU for 5 days, and then in the special care nursery for another 3.5 weeks. And every day we were there. We were fortunate to be there every day, I should say. In this picture, you can see I'm doing Kangaroo Care while Nate is reading a book. We were reading The Power of One, so definitely not a children's book, but we read it to him every single day, multiple times a day. And now he's a happy, healthy, astute kindergartner who's just wild, and he is in the 80th percentile for his height, 90th for his weight. He has no lasting health concerns from his time being born so early and weighing so little. And you know, this was just our natural innate thing to do, and Nate was involved in Reach Out and Read. But it really helped us as a family, because even though both of us are in healthcare, being in the NICU is very scary. And even though we knew how to navigate it, there was just so much unknown. So it was nice to have something to turn to that we knew what to do, what was good for our child.
Thank you, Jenny. And thanks again to Lauren. We have a lot of chats, and I see a couple questions, but I want to start by kind of turning off the slides and opening it up a little bit too, because I see that Dr. Gigi's here now, and we have Dr. Bendel on as well. Gigi, do you have any questions or comments or things that you want to share to start us off?
Well, thank you everyone for such an amazing presentation. Dr. Buckley, that was phenomenal. And Jenny, thank you so much too for sharing just how personal and how impactful reading is, especially for neonates. And Dr. Buckley, I guess my first question to you is just to wonder how families have received this in the NICU. And I can imagine my own projection of that would be that there's so much out of, I think Jenny alluded it too, there's so much out of control, out of a parent's control in the NICU, and so much technology that this could give back and create some sense of just normal parenting interactions that parents can have with their little ones. But I was just curious to know if there's been any ability that you've had to really hear directly from parents about that.
Yeah, thank you so much, Dr. Chawla. That's really what it's all about. And yes, we've had very positive feedback from families that they think it is so cool that they get to take these books home. They feel empowered to spend more time holding their babies, and I think really just gives this sense of I can do this. I can't force my baby to eat faster. I can't wean them off of oxygen on my own, but I can provide my touch that no one else can. And I think that that's been really wonderful for our families. And I don't know if Dr. Bendel has any story. She really works a lot up with those patients, much more than I do. But I know she's had some positive interactions with families about it too.
It has been just really so wonderful for our families. As Lauren, Dr. Buckley said, I attend a lot on the 11th floor unit. And I think one of the things that I've noted, a lot of the babies have come from our 4th floor unit, super ill, maybe already been in the hospital for a few months, and they're coming up to spend sort of their transitioning time before they go home, where it's going to be less intense. They have a private room. And one of the major goals is to really help parents learn how to parent, to become more comfortable parenting their children. And that's always been a struggle. Oh, I can't do it. They're so fragile, this or that. And this has just been an amazing addition to the toolbox to make it a more comfortable environment for them, to make it more home-like, and to let them do something that's really parenting. There's no medicine involved here at all. It's not helping with the tube feeding or, something like that. It is really the same sort of thing you'd be doing at home with your baby if you were at home. And the parents, so many parents, one of the families that was pictured in Dr. Buckley's display, the couple that was there, they actually set aside a particular time period every single night to read either the book we had given them or book that they had brought from home for their baby. And so, Lauren and I are hoping to do a little more formal assessment of this, but the initial feedback that we're getting from parents is nothing but positive. And the other thing is that we really have tried to have as many multilingual books as we can right now, and to really help allow them to give that has been so appreciated by our non-English speaking families, to have a book that they can read to their baby in their own language.
Thank you. Yeah, I think that that's really important. And I think as we were going through this and working with Julie, who is the Reach Out and Read coordinator at Fairview, when we're doing the normal Reach Out and Read program, we're really focused on sort of the developmentally appropriate books for the very different ages. And when we looked at this program, and I think to Jenny's point about what they were reading, it was like, we want to have beautiful books that parents want to read. And yes, we have a budget, but we want to have books with stories. We want to have books that people are going to want to read over and over. And if that, reading leads them to bring in their own magazines or newspapers or whatever they feel like reading and read that too, that's great. So it was nice to kind of take a step back, take a re-inventory of our book catalogs, and then think what's going to work best in the NICU. And Dr. Buckley, there were a couple of comments praising the ideas and inventiveness you had with getting everyone trained and incentives to get people trained. I know that was a big hurdle, and I think to those I think you did a good job to those thinking about rolling this out at their NICU. I think thinking about it as it's going to take more time than you probably expect.
Yeah, right? Double or triple. It took us almost 2 years from let's start our application. And part of that was just living and learning, and certainly the time period that we were in with COVID and the number of online modules that people were being asked to do, and ours wasn't required. So that made it very challenging. But I would say that'd be the only thing, is if there was a way, if we could go back, initially we thought that it would slow things down if we went through the nursing union and Fairview specifically and got it as a required module. We felt like this would be faster. In retrospect, I do wonder if we had actually spent the time to get it to go through the LMS, if we would have had more success, just because, I mean, and this is even, people wanted to do this. It's not like anyone was saying, oh, I don't want to encourage families to read to their babies. It's just that fatigue is real, I think, with anything that's kind of checking a box or completing trainings right now.
Yep.
But I also see the hospital now sees the utility of this program. They've been very pleased with the comments from families on, end of hospitalization surveys, as well as some of the publicity that the program has gotten. So I think moving forward, Dr. Buckley, it's going to be easier for us to work through the system to train new individuals and to help this move forward.
I think, speaking as a nurse too, and having to do the required modules in the hospital, I think you almost want it to be not required, because the required modules are just click, 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 click. So the folks that are doing it are really engaged and wanting to learn. So I think keeping those incentives makes it more meaningful.
That's a good point. We had a couple of questions. One logistical question that I think is important to touch on. how soon you're introducing the NICU program, the ROR NICU to families, noting that the first few days can be especially emotional. And so then kind of the question is there a schedule and a plan for when you would suggest it? And how have you worked out those logistics?
That is such a good question. So the way we have rolled this out is a little bit unique than probably what many other NICUs would have, because we are just in this intermediate care center where it's relatively uncommon that we admit babies there, actually. So we do occasionally have kind of less sick babies that'll go straight to the 11th floor, but the vast majority, as Dr. Bendel was referring to, are actually admitted to the 4th floor for some period of time that could be days, weeks, or months. And then as beds open up or they stabilize, come up to the 11th floor. For really simplicity's sake, we made it so that we have 1 day a week that is reach out and read book day, and every baby that happens to be there on that day gets a book. So theoretically, if they were admitted directly to 11 on that day, they would get a book that day. And there are maybe other babies who are 3 or 4 months old by the time that they make it up there and are getting their first book. So I think for us, it's been much more about just logistics and feasibility than probably what is the ideal time for each baby in relation to their development. I think we feel that everyone up there is stable enough that it's, certainly would be reasonable for their family to hold them and read to them. But it's definitely something we're going to have to think more about when we expand to our 4th floor, because we have some babies down there that probably won't benefit from the additional stimulation of reading when they're so sick. And we see babies who any sound causes their oxygen requirements to go up, and it can be really a lot. So I think the Boston Medical Center article, I believe they kind of talked about when stable. So they often, I think, waited maybe a week or 2 for their kind of routine preemies, but they kind of targeted it towards the individual patient. It looks like someone in the chat is talking about 33 weeks maybe is the cutoff for their OTPT. Yeah, I think that seems very reasonable as well. And that really gives you about a month or so before most babies are ready to go home to kind of start growing that library and working on it.
Great, thank you. There was a question about, I'm just scrolling up to it, and this is, a good question. What follow-up are you planning to validate the importance of this work, and how can we follow it, and how, I guess, more generally, are you thinking about research on this and anything upcoming that you might be able to share about how you're thinking about this?
Yes, that is such an important question. We designed this when we first, we actually talked a little bit about that when we first started this project, is do we want this to live in kind of research bucket versus what's more a quality improvement bucket, which in healthcare we think about as something we already know is beneficial, and we're kind of measuring how we're enacting it and how we can improve the care by doing things we already know are good. And so we felt like with the time and the resources we had and just other projects that we're working on to focus more on that quality side of things. So this is not, we are not personally doing research on the babies that we're giving books to. Now, that being said, I am, just starting a career there. I am very interested in this topic. I would absolutely love to collaborate and to think about in the future how we can operationalize that. We are really fortunate to have a very robust NICU follow-up clinic program at the University of Minnesota because of our emphasis on neurodevelopment. So I really think the infrastructure is there that we could do, at a minimum, surveys. We've even talked about continuing to give out books at that NICU follow-up clinic. That's on my list of things to investigate. But I think that's an incredibly important question. The more data we have that this is beneficial, the more we can, support families and, raise awareness. So definitely something to think about.
So very well said, Dr. Buckley. And I just want to tag on two quick comments. I think her comments about the infrastructure being there and the interest as well. Our entire group really is interested in outcomes and neurodevelopmental. And so now that we have it up and running, I think we can set up a good way to measure some outcomes through our follow-up clinic very clearly. But I also wanted to say that I'm really supporting Dr. Buckley's idea and hope that we can continue to give out books in our follow-up clinic. We have established a philanthropic fund to just support buying books for the NICU. And I would just love to have that be the next step in building that library for the family, like Dr. Chalo wrote in her comments that, you know, it's like, hey, you haven't left our family yet, and we're going to give you another book now to add to the books that you took home from the NICU with you.
Absolutely. I think that we've managed to get through the questions that were in the chat. And we try to let people leave a few minutes early from these events and move on to their next meetings. I do want to point out that the coordinator for the lead for the Hennepin Health NICU program has offered some great information in the chat. And we'll make sure for everyone on this, we will send out a link to the recording and we will include that information. As has been pointed out, we have some key takeaways, but we know that every NICU operates a little bit differently. And so as we've done it, as Reach Out and Read coordinators have done it, we've sat down and we've had to talk through kind of what this looks like at each different NICU. And so she did put her email in the chat section if people are interested in following up to see how Hennepin Healthcare's NICU is doing the program. But I want to thank everyone, all of our panelists that were on today, and I want to also thank all of our very active chatting attendees today. And we hope that you've learned something, and I certainly learned a lot. And we will send out a link to this recording after. Thank you.
Thanks so much, everyone.
Thank you, Chris, for hosting this as Reach Out and Read and honoring the excellent work that Lauren did making this happen as a fellow.
Absolutely. Thanks all.